اهدنا الصراط المستقيم الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين. Amen. And after that, let's offer prayers and peace be upon our beloved Prophet Muhammad, Hazrat Muhammad, his family, and his companion. And I'll be moderating the session. And before I say a few words about GoRed, I would like to introduce the panel of experts. And what a panel, a galaxy of the presidents. We have the incumbent president, Professor Mahmoodul Hassan. He heads the Department of Khyber Teaching Hospital, Karachi, and he is the incumbent president, Cardiac Society. He was preceded by Dr. Javed Sayal. He's marked absent, and his predecessor, General Sohail Haziz, is not here. His predecessor, Dr. Harun Babar, not here. Very bad behavior. And the president-elect Rajkumar. And then, above all these presidents, our very honorable, beloved ex-commandant, Armed Forces Institute of Cardiology, which is the host institute, Major General Khurram Shehzad. So, हम तीन के लिए clapping कर दी जाए. अब जो नहीं आएगा ना वो नीचे बैठेगा. मैं थोड़ी देर बाद एक दो को और ऊपर है. Oh, I'm sorry. And the most senior cardiologist, Professor Dr. Nazir Memon. He headed the different institutes at Hyderabad and is now working in different capacities and has always been active in these meetings. Awfully sorry, Dr. Nazir. But anyway, jab bhool na jaat to reh gaya. Okay, with that, I would like to say a few words about what this program of GoRed is all about. You know that you can see the hall. This is the importance our society, especially in South Asia, that imparts to the women. And there were previous misconceptions that younger women do not fall a victim to cardiovascular problem. And it was the breast cancer that was #1 killer in women. And if a younger woman, that is in her 20s, 30s, and 40s, complained of any pressure on the chest or shortness of breast, she was labeled as a case of broken and a bereaved heart. So years later, people discovered that if not all, many of these bereaved hearts were the diseased hearts to begin with. So, seeing that, and in year 2004, 500,000 women died only in United States of America. And the irony was that neither patients nor physicians were aware of the fact. So then they came up with a signature program, GoRed for Women. And in Pakistan, it was launched in 2007. Professor Khalda is chairperson. I am vice chair. And then we have different coordinators for different. Dr. Rajkumar, कहना तो नहीं चाहिए था पर आप आ जाए. अच्छा, लेट आने वाले को मैं नहीं वो माफ करती. Anyway, so we've been doing these GoRed events, although sometimes we have just the panel of experts and the speakers, but we never gave up. And now, since, Sadr Mamlakat ka ohda bada important hai, khaskar Pakistan mein. So Professor Mahmoodul Hassan, being the Sadr Mamlakat of Pakistan Cardiac Society, before we start off our formal session, I would request him to say a few introductory words about this GoRed for women in Pakistan. बहुत बुरी बात है. 5 minutes late.
Bismillahirrahmanirrahim. Thank you very much for your introduction. And for the last so many years, we have been seeing GoRed in Pakistan, and in particularly the efforts and the endeavor of Madam Khalda Sumro has been tremendous. And she is constantly involved and knocking the different forum for the awareness of the women health. She is a pioneer, and definitely she is working not only in the forum of Pakistan but also abroad. And we are very proud of that. Every session and every conference in Pakistan, which is there is a separate session for GoRed for this awareness program and activities. So we have a scientific council, and she is the leading person on that. And when I became the president of Pakistan Cardiac Society, my objective was that beside other symposium and activities across the country for awareness, why not we should have a data. And for in this regard, Madam Khalda Sumro is working. She's in the process of preparing different registries about the health of women, and particularly in reference to the cardio-oncology, gynae, and acute coronary syndrome in women. And inshallah, soon we will be seeing our local data from our own population, and based on data, we would be able to know what is the depth of the disease in Pakistan in women, and what is the age, what is the common factors which are affecting this disease, cardiovascular disease in women. I thank you and very much for inviting me on this August forum. Thank you very much.
Thank you. And now we start our session. I'm told that the speaker on Zoom, Dr. Nanette, is not ready for her presentation. So I would request any one of two. We have Professor Khalda Sumro and Tahira Sadiq, who would offer to speak first. Dima is online here anyway. Okay, so we have another speaker from APSC, Dr. Dima, who is assistant professor at the Cleveland Institute of Cardiovascular Diseases at Cleveland, Ohio. So she's going to talk about the role of microcirculation and pathogenesis of heart disease in women, how to treat and how to manage that. So Dr. Dima, a very warm welcome to you from the scenic place of Bhurban Murray and from GoRed, Pakistan. Dr. Dima, please.
Good morning to this wonderful panel. I want to thank you for inviting me to speak on such an important topic, and I congratulate you on your conference and efforts to highlight women's heart health. I won't take too much of your time. I'm just going to share my screen.
Dr. Dima, just a request. You are requested to complete your talk within 10 minutes, okay?
All right.
We don't. Okay, thank you. I shall be grateful.
All right. So I won't, without further delay, so I'll be talking about microvascular dysfunction in women. I'll start with a case. This is a patient that was referred to the Women's Heart Clinic, a young 38-year-old female who presented with a year history of exertional shortness of breath and fatigue, to the point where she was avoiding strenuous activity. In addition, she had left-sided chest pain that was radiating to her shoulder and palpitations. Her past medical history was significant for lupus that was diagnosed in 2015. She had no history of adverse pregnancy outcomes, such as preeclampsia. And I have her cholesterol panel, which is normal, no other traditional risk factors. So for her chest pain and palpitations, she underwent a Holter that was normal, an echocardiogram that was normal, and then an exercise treadmill test. And she was only able to walk 6 minutes and 30 seconds and stop due to the same pain that she presented with, and shortness of breath. And you can appreciate here that she has these non-specific ST depressions and several leads. And because of that and her low functional tolerance, she underwent a cardiac CT that showed, as you can see, a coronary artery calcium score of 0 and no evidence of atherosclerotic disease on her epicardial coronary arteries. So several years ago, I would have probably stopped there. I had a young woman, no major risk factors, and we've excluded epicardial coronary artery disease. But fortunately, because of her history of lupus, there was a concern for microvascular disease, and we pursued a cardiac PET. So on the left side of the screen, you can appreciate her perfusion images that are unremarkable. There's no perfusion defect. But what cardiac PET also can delivers to us or can demonstrate to us is what it offers us is the regional and global perfusion quantification. And in this patient, and I'll talk about this a little later, she had an abnormal coronary flow reserve, meaning that she was unable to increase flow to all of her myocardium with pharmacologic induced stress. So normally the CFR should be above 2, and she was not able to even double her flow. And this is a sign of microvascular dysfunction. So what is coronary microvascular dysfunction? For years, we have gotten very good at diagnosing and treating epicardial coronary artery disease. But as you know, this only represents 10% of the coronary or the myocardial vasculature. We have to remember there's these arteries branch out into smaller vessels that are not visible to us, but that are there. And that is what we're going to talk about. So women are more likely than men to have no evidence of obstructive CAD on cardiac cath. And this is with all presentations, whether it's stable angina, where 2/3 of women have no obstructive CAD compared to men, but also in the setting of non-STEMI and even STEMI. 10% of women who present with an ST elevation MI have no explanation for their presentation based on cardiac cath. And this is important even in younger women in whom we're seeing a rise in cardiovascular mortality lately. So in these registries, if we look at the bottom one here, compared to men, so younger women, younger than the age of 50, you have 14% of them who have no evidence of obstructive CAD on cardiac cath compared to only 6 or 3% of men. Yet, for 30 years, this is data demonstrating mortality in men and women in the US. And for 30 years, more women died from heart disease in the US than men, and yet they had less obstructive CAD. So this is what we call the woman paradox. And this led to an interest in understanding heart disease in women. And one of the studies that really informed us about how heart disease is different in women than men is the WISE study, the Women's Ischemic Syndrome Evaluation, that was initiated in 1996. And the purpose of the study was really to try to understand, do women present differently? Could there be a difference in ischemic heart disease in women? And in their initial cohort, they had 936 women who had presented with angina or ischemia and who underwent coronary cath. And as I said earlier, 60% of these women had no evidence of obstructive CAD. And one of the major takeaway messages from the WISE study was that we can't use the word coronary artery disease in women. It's really only the tip of the iceberg. And we should be using ischemic heart disease in both men and women, but particularly in women, because really coronary artery disease only reflects the tip of the iceberg, and ischemic heart disease can be due to many other pathologies in men and women, in women particularly. And the second takeaway message from the WISE study was that this is not a benign entity. So like the patient I showed you, if I had dismissed her, she was going to come back. And when they looked at the 5-year rates of cardiovascular outcomes in these women, both women with completely normal coronary arteries or non-obstructive CAD compared to women from the community with no symptoms, the WISE women were more likely to present with an MI later, to present with with heart failure, and more importantly, to die. So they had a higher rate of all-cause mortality. So this is not a benign entity. What are the risk factors? So they do share the same traditional risk factors, but the traditional risk factors don't account or can't explain the presence of CMD and other risk factors include a history of inflammation, as in the case that I demonstrated, and a history of breast cancer chemotherapy. So what is microvascular dysfunction again? So we have to just review the anatomy briefly. You might remember from medical school that the epicardial coronary arteries branch out into prearterioles, arterioles, and ultimately capillaries. And this is where the exchange of oxygen occurs. And at rest, we're already extracting near maximal oxygen. So if the myocardium needs more oxygen, it cannot extract more oxygen. The only way it can obtain more oxygen is by increasing blood flow. And this is regulated at the level of the prearterioles and arterioles. That's where 80% of the resistance occurs. And normally, in a normal myocardium, we should be able to increase myocardial blood flow by 3 to 5 times. And this is based on data in men. And this is all nicely regulated by at multiple levels. The endothelium can excrete nitric oxide and acetylcholine that can lead to vasodilation or vasoconstriction. There's different levels. And just because of time, I have to say that any abnormality at any level, whether it's endothelial dysfunction and impaired production of nitric oxide, vasoconstriction, any abnormality at any of these levels will lead to microvascular dysfunction. So microvascular dysfunction is still very heterogeneous. So it can be a functional problem, meaning that the endothelium, for example, is impaired, and instead of, for example, vasodilating in the presence of acetylcholine, it might lead to vasoconstriction. You might have impaired or less nitric oxide that can lead to less vasodilatation, but it can also be structural in the setting of fibrosis, edema, and whatnot. So how do we evaluate it? These are small vessels that we cannot see. So the only way to assess for CMD is to measure basically coronary flow at rest and then at stress by inducing hyperemia. And that can be done non-invasively or invasively. Non-invasively, most of the studies have looked at the role of cardiac PET. That tends to be the gold standard. It is costly and not readily available. There have been more studies looking at CMR, and in some labs, Doppler echo by pulse waving the proximal LAD, you can assess coronary flow at rest and then by inducing hyperemia. So like I said, cardiac PET is the gold standard. It is a pharmacologic stress, so it's not an exercise stress. You have to induce hyperemia with a vasodilator. And as I showed in the example, you obtain perfusion images, and then you can measure CFR. And the cutoff is 2. So anything below 2 is abnormal. And the lower the CFR, the worse the prognosis in both men and women. And this is a study that was done in the group in the Brigham. So they looked at how prevalent is this? So they looked at patients that were referred for symptoms or signs of ischemia. And even though they had normal myocardial perfusion images, 50% of both men and women in the study had an abnormal CFR. So it's not uncommon. And in both men and women, having a CFR below 2 was associated with a higher risk of MACE. Predictors of mortality in CMD is having non-obstructive CD compared to completely normal cath. Like I said, the lower the CFR, the worse the outcome, and ongoing symptoms. So if these patients continue to have chest pain at 1-year follow-up, their prognosis is worse. More and more, we're moving towards invasive assessment because it can provide us with a more comprehensive assessment, meaning that with invasive assessments, you can measure flow either by thermodilution or coronary Doppler, and you can measure coronary flow at rest and then by inducing hyperemia with infusion of adenosine. And that allows you to measure the CFR. Again, the cutoff is 2. In some labs, it's 2.3. But the advantage of invasive assessment is you can also measure resistance. And if the endothelial dysfunction is ruled out, meaning that the CFR is normal, you can also complete the evaluation with an acetylcholine testing to look for vasospasm.
Excuse me, Doctor. Being the host, I hate to interrupt you, but as I requested in the beginning, the time is up. And I want to
this is the last slide. So I just want to terminate or end with talking that there is unfortunately no treatment options as of now. There are no guidelines to guide our treatment. This is a table just listing all the medications that are currently being evaluated for potential therapies. And currently, what we recommend if you think you're dealing with microvascular angina because of endothelial dysfunction, we're using beta blockers, calcium channel blockers, statins, and ACE inhibitors. And then for vasospastic angina, where there's evidence of spasm due to acetylcholine, you're using calcium channel blockers. There is one study that will be looking at the role of statins, ACE inhibitors in these women. And I'll end here. Thank you very much.
Beautiful beginning of our session, GoRed for Women Pakistan. I'm sorry I had to interrupt you because, yes, you talked about microcirculation. It plays a very important role. As a matter of fact, in women, it is 60 to 80% of the ladies who do not have obstructive coronary artery disease, and it's the diseased microvasculature that is at fault. And for this very reason, women do not have the classical symptoms of central chest pain radiating to the arm with sweating and all that. Symptoms are vague because, small blood vessels are everywhere, and it does not affect only the coronaries. There's a network of microvasculature, and everywhere it stiffens, and with the result, each attack, may that be in epigastric chest pain or shortness of breath, myocardium loses its resilience, and then very often these patients come to us at the stage of congestive heart failure with a big heart. Thank you so much. Do we have time for question answer? If anyone wants to ask a quick question, or shall we go to the next speaker? Okay, if there are no questions, the next speaker is from Pakistan, that is Tahira Sadiq, as ex-wing commander, and now she's working as consultant cardiologist at Maroof International Hospital. She is going to talk on the role of hormone therapy in women.
Rahmanir Rahim. Very good morning to all of you. I'm very grateful for Professor Khalda and Professor Nusrat Tara and rest of my senior colleagues to invite me here. Today, I'm going to discuss a very controversial and very newer topic, that is hormone replacement therapy in women regarding cardiovascular health. So, before going to the topic, let's briefly discuss about the facts of cardiovascular diseases in women. Still, it's #1 killer in women, and 20% of the women who are living today, they have to go through pregnancy, and during pregnancy they suffer from high blood pressure, preeclampsia, and gestational diabetes. And you know that 50% of these diseases, they stay with them. So this is a very important risk factor in a women's life. 51.9% of high blood pressure deaths occur in women, and you know that it is a silent killer in females. Almost 4.1 million female stroke survivors are living today, and 57.5% of total stroke deaths occur in women. So females are definitely different from their male counterparts. They present very less, and most of them suffer from atypical symptoms. And it was a myth before that heart attack occurs only in males. And there are many myths about the hormone replacement therapy. Today we are going to discuss about many of those myths. So due to increased stress and sedentary lifestyle, there are more heart attacks in women at a younger age group. And as Dr. Dima was previously discussing, that females have unique pathophysiology for cardiovascular disease. They have smaller coronaries, and they have poor prognosis if they develop a heart attack at an earlier age. So I'll briefly discuss about the gender differences in coronary heart disease. 23% of women suffers from death post-MI as compared to 18% of men. And similarly, in heart failure, 22% of women have the mortality versus 16% in male counterparts. And same goes for the stroke, 7% of women versus 4% of men. So, in the women who have suffered a heart attack, there are recurrent MI and fatal coronary artery disease in 21% of them as compared to 17% of men. So, the mortality goes up in the female counterparts. So, what is the difference between a woman and man's heart? It is known that incidence of cardiovascular disease in women lags behind men by 20 years, which means that if a male suffers heart attack at an age group of 60, a female have got more chances to be saved from 40 years to 60 years. Why is this delay in the onset of cardiovascular disease? It appears that the estrogens, they have a cardioprotective role. So after menopause, the incidence of heart diseases occurs more in female as compared to men. So age-specific cardiovascular incidence is 2 to 6-fold greater for postmenopausal than premenopausal women across the age range from 40 to 54 years. There is a bar chart, and you can compare that in younger age group, in the premenopausal, the pink is for premenopausal, you can see there is 0.6% incidence in 1,000 women. And in the postmenopausal women, that is if a female has menopause at an earlier age group, the incidence of coronary artery disease goes by 2 to 4-fold. And similarly, in the rest of the age groups, you can see the postmenopausal women have more incidence of coronary artery disease. So, is really age a number? We all hear every day that age is just a number. I think age is not really a number, because we see that cardiovascular disease is age-related and very much age-specific according to the Framingham study, which was done many years ago. And I'll discuss later on that there are many current studies which also support the Framingham study. So endogenous estrogens, they are really cardioprotective. And it provides us the opportunity to use HRT for cardioprotection. There are two main hypotheses regarding HRT in women's. One is the timing hypothesis. And the timing hypothesis states that we can use the endogenous estrogens cardioprotective effect if we start them in the premenopausal women, not after the menopause, because they have very effective and healthy effects on the endothelium. So if you see in the natural progression of atherosclerosis, the estrogen receptors are present in this age group when it is the premenopausal area. After the age group of menopause, that is above 55 years, basically the estrogen receptors decline. And that's why if you start HRT in the postmenopausal area, it will not give you the positive results of cardioprotection. So there are many recent trials. The first trial I'd like to discuss briefly is estrogen in the prevention of atherosclerosis, EPAT. And the second trial was done, women's estrogen progesterone lipid lowering hormone atherosclerosis progression trial, or the WELL-HEART trial. So in EPAT trial, the estrogen estradiol was given, and you can see how they monitor the results. They monitor the carotid intimal thickness change per year, and the study was conducted over 5 years. And you can see in the placebo group, the intimal thickness was on rise, but when they given the estradiol, the intimal thickness rather reversed. And in the WELL-HEART trial, they used the angiography as the gold standard method, and the percentage stenosis difference was observed by doing the angiography. And in placebo group, there was no interval change. In estradiol group, still there was increase, but when they gave estrogen along with progesterone, there was a decrease in the stenosis. So a meta-analysis was conducted and it included elite and women health initiative, EPAT, and there were 23 randomized controlled trial. And this meta-analysis demonstrated that HRT significantly reduces all-cause mortality by 39%. And another meta-analysis showed that when initiated in women less than 60 years of age or less than 10 years since menopause, it definitely gives you a reduction in mortality. And the HRT trial on all-cause mortality and coronary artery disease was null when initiated in post-menopausal women or after 60 years age group. So HRT is indicated in women to overcome the short-term and long-term consequences of estrogen deficiency. That was the first indication of HRT. The previous indications of hormone replacement therapy were to relieve the menopausal symptoms, prevention of osteoporosis, and to maintain the quality of life. And there are two special groups in which the HRT is indicated: the premature ovarian failure, surgical and radiation menopause. I think interventional female cardiologists, they at a younger age group, we are also having these problems in young females.
Tahira?
So, yes, ma'am. Only two last slides, ma'am. So, there is a smaller risk of endometrial cancer, breast cancer, venous
अगर मेरे बस में होता
thromboembolism.
मैं वहाँ से माइक बंद करवा देती.
Okay. So, remember the treatment options, estrogens, and there are many combinations available. You can use them. And I'll not go into the detail.
Yes.
The take-home message today is that HRT is beneficial when initiated in timely fashion. So start it in the perimenopausal women. Thank you.
Thank you so much, Tahira. And thank you for honoring my request, but rather late. Anyway, it's better late than never. Okay, so now before I make comment on her presentation, our worthy chairperson, Brigadier General Khurram, wants to ask a question or wants to make a comment.
Dr. Tahira, very good presentation, and thanks for this very illuminating talk. I have a question. Is there any role of hormone replacement therapy in guidelines? Have they found a place in the guidelines? Number one. Number two, when we give hormone replacement therapy in perimenopausal women, we are interfering with the nature. So, what are your comments? Should we interfere with the nature? And thirdly, the patients who have established coronary artery disease in premenopausal age group, do they warrant hormone replacement therapy as a prevention in preventing the progress of atherosclerosis in this postmenopausal time? So these are three questions.
Sir, thank you. I looked into the guidelines, and definitely previously there was no placement of hormone replacement therapy. And now after these meta-analysis and RCT trials, we are expecting that the new guidelines will allow this. And although this, I showed you the slides, in some cities it has shown that there was significant difference in the percentage stenosis. So I think you cannot play with the nature, but you can use the cardioprotection benefit of estradiol in selective group, and you have to individualize the treatment. In premature ovarian failure, that is, I think, the most important special subgroup in which you can use the HRT.
Sorry, excuse me, let me add one thing in it.
डॉक्टर साहब एक मिनट में उससे पूछ लूँ because the next speaker is ready on Zoom. अगर हम पहले उनको लें बाद में, it's a very interesting topic. Our chairpersons have to ask you many questions. So what do you suggest? खालदा हमें पहले नैनेट को ले लें because she is ready. क्योंकि Zoom पे तो फिर वो मुश्किल हो जाता है. Okay, our next speaker happens to be Dr. Nanette Ray. She is from Health Sciences Institute. She is assistant professor at Health Sciences Institute of Manila. Dr. Nanette Ray, please. She's going to talk about women and heart diseases. Dr. Nanette Ray, please.
Association, and today I will talk on cardiovascular disease in women. But before I proceed, let me take this opportunity to thank Professor Khalida Sumbong for the privilege to join you in your annual cardiology conference. Cardiovascular disease remains the leading cause of death, not just in men, but also in women. The lifetime risk of developing cardiovascular disease for a 40-year-old woman is about 50%, with 33% risk for developing CHD and a 20% risk for developing heart failure and stroke. Awareness of cardiovascular disease as a leading cause of death in women has increased to 56% by 2012, but has remained suboptimal, especially in racial and ethnic minorities. Traditional risk factors for CVD in men are also common in women, but currently there is no known genetic marker that can be used to improve the risk assessment for women beyond the traditional risk factor identification. However, there are emerging risk factors for women which can predispose to early onset of cardiovascular disease. The Interheart study found 9 factors that account for 94% of population attributable risk for acute MI in women and 90% of risk in men. These are ApoA, ApoB ratio, cigarette smoking, hypertension, diabetes, abdominal obesity, psychosocial factors, fruit and vegetable intake, exercise, and alcohol intake. Of this, diabetes and psychosocial factors have been found to have a greater association with the risk of acute MI in women. On the other hand, lifestyle choices, including exercise, fruit and vegetable consumption, and modest alcohol consumption, were associated with a greater level of prevention of MI in women compared with men. The Framingham risk score stratifies women into 3 risk categories. Premenopausal women with symptoms are considered low risk. Symptomatic women in their 50s are considered still low ischemic heart disease risk if they can perform routine activities of daily living. Once ADL is impaired, they are considered intermediate risk category. Women in their 60s are generally considered intermediate risk, while women in their 70s are considered high risk for CAD. Women tend to report atypical symptoms of ischemic heart disease compared to men. Absence of chest pain was more common in women than men, and it is quite common for women to present with an MI without any chest pain at all, particularly for the younger age group. Common symptoms of IHD for women would include shortness of breath, pain or discomfort in other body locations, indigestion, nausea or vomiting, diaphoresis, faintness or dizziness or syncope, fatigue, general weakness, or palpitations. More often than not, the symptoms would often occur at rest or stress-related based on the women's ischemia syndrome evaluation. Diagnosis therefore becomes more challenging for women. Routine exercise ECG is the usual recommended diagnostic modality, but other non-invasive imaging like pharmacologic myocardial perfusion imaging, echocardiography, cardiac MRI, or coronary CT may be recommended for women with intermediate risk and an abnormal resting ECG. Although false positive stress ECG in women may be quite frequent due to resting STT wave changes, a negative test is particularly diagnostic. The positive predictive value of stress ECG in women is quite low at 47% versus 77% in men, but the negative predictive value in women is as high as 78%. Optimal medical therapy for CAD does not differ for men and women. However, women tend to receive less intensive medical therapy or lifestyle counseling compared to men. Data from WISE also show that women tend to have less anatomic obstructive CAD and more preserved ejection fraction, despite higher rates of myocardial ischemia and mortality compared to men. Contributory to myocardial ischemia pathophysiology in women would be adverse coronary reactivity, microvascular dysfunction, and plaque erosion or distal microembolization, which should be important considerations when dealing with CAD evaluation in women. Non-obstructive MI also occurs more frequently in women, particularly the younger women. All-cause mortality rate appears lower in MINOCA compared with obstructive MI, but is still substantial, and several possible causes have been implicated in MINOCA, like spontaneous coronary artery dissection. The WISE study showed that 57% of women with signs and symptoms of ischemia have no obstructive CAD by coronary angiography, but more than half of these women will continue to have signs and symptoms of ischemia, undergo repeated hospitalizations, and will undergo coronary angiogram. Symptomatic women tend to have a higher rate of mortality and adverse cardiovascular events compared to asymptomatic women. Hence, it is important to remember that women with signs and symptoms of ischemia are not benign even in the absence of obstructive CAD. Microvascular angina, also known as cardiac syndrome X, appears more common in women, probably due to hormonal factor influences. Approximately half of women with microvascular angina have microvascular coronary dysfunction, resulting in ischemic heart disease adverse outcomes. Deaths due to heart failure also appear to be more common in men than women. Risk of heart failure in women 40 years old without prior MI is lower compared to men, but the prevalence of heart failure in women progresses with age, with more women having heart failure after 79 years. Breast cancer incidence may also affect cardiovascular disease in women. Cancer therapies may have cardiovascular effects, which may include no-onset hypertension, ischemic heart disease, whether due to atherosclerosis or coronary artery vasospasm, cardiomyopathy, arterial thromboembolism, and arrhythmias. Women also tend to respond differently to common cardiac medications, which may alter some of the cardiovascular therapeutic choices for women. Therefore, we are now faced with the reality that there are indeed gender differences on cardiovascular disease for men and women, and there are gender-specific risk factors that may account for the atypical cardiac manifestation and the higher risk for mortality in women as compared to men. As such, it is important for women to be aware of these gender-specific risk factors apart from the traditional risk factors. We need to go red. Get your numbers, know your risks. You are responsible for your own safety and you are primarily responsible in educating your own families. So go on and spread the message. Do not be silent. When cardiovascular risk factors and symptoms are recognized early, women fare better when treated according to existing guidelines. Education and awareness are paramount in order to decrease that disparity between care for women and men with cardiovascular disease. Remember, what applies to Adam does not always apply to Eve. Thank you very much for your kind attention.
Did not give me a chance to remind you of your 10 minutes. It's wonderful. Thank you so much. And yeah, I'm extremely grateful. Now, Dr. Nanette, you talked about heart diseases in women, and the basic difference, as I've always been talking, if you remember in men, these atheromas, due to these risk factors, they protrude into the lumen of the vessel. So when you do angiography, you can say that it is 10%, 20, 30, 40% obstructed. In women, it is so very unfortunate that you do have the disease, but it grows inside the wall of the vessel, it causes ulceration, and these ladies, they have positive stress test, but when you do an angiogram, the report is normal coronary artery. Because to detect a lesion like that, you have to have an intravascular ultrasound, which we do not have here for diagnostic purposes. I've often seen a woman being given a clean chit after angiogram. Aapka dil bilkul theek hai, jaएं ji enjoy करें, to learn only weeks or months later that so-and-so went off to sleep and never woke up. And with that, I think we have saved plenty of time for Khalda. Are you ready for your presentation? I would now request Professor Khalda Sumro for her presentation. Again, the same topic. She's going to talk about Dr. Shahbaz, आखिर में नहीं पूछ लेंगे? अच्छा, अभी वो स्क्रीन पे है, उससे पूछना है. Okay. Dr. Nanette, Professor Shahbaz Qureshi has a question for you, please.
Dr. Nanette, thank you very much for an excellent presentation. You talked about the heart failure in your patients with ischemic heart disease in women. You did not allude to heart failure with preserved ejection fraction, because a large majority of women, as they age, they develop heart failure with preserved ejection fraction, and we should not forget that. That is one comment. And the second regards Dr. Nusrat. She talked about the exercise tolerance test being positive, but no obstructive coronary artery disease. You see, in women, the problem is that the electrocardiogram is non-specific, and the exercise tolerance test, which is done in them, cannot be interpreted in the same manner as the exercise tolerance test in men. So I think one has to take it with, you have to be very careful when you see these patients, and it would be much better to add a cardiac imaging to it, like even, for example, stress echo, or you can use nuclear stress imaging in your patients, and that would probably increase the positive value in your patients.
Thank you so much, Dr. Shahbaz. And now I request Professor Khalda Sumro, who is the chairperson of GoRed for women in Pakistan, and she's also the past president of Pakistan Cardiac Society. Dr. Khalda is going to talk about ischemic heart disease and, how to manage and different aspects of ischemic heart. Thank you. Dr. Khalda, please.
My lecture was not planned because Dr. Ambar Ashraf was supposed to give talk on the heart failure, but to save the time and there were two speakers online, so I thought I can aid this presentation, which maybe I may repeat the same thing from the previous lectures as well. So coming to the optimization sex-specific cardiovascular assessment and prevention for the women. This will be the topic of my talk today. As our other speakers told us that there is increased death rate in women than men, despite of the fact that CVD is more common globally in the men. This death rate is contributed in women, pregnant women with CVD. My focus of the talk will be today on the pregnant women with cardiovascular diseases and their mortality. So, apart from the common risk factors which are more in men and which are more in the women, my focus will be on the pregnancy complications and this endocrine disorders, disorders in the women. As I have already told you that there is increased death rate because of the during the pregnancy because of the cardiovascular disorders, and these could be unknown also. Later on can be diagnosed during the pregnancy. So, according to AHA, prevention of CVD is paramount to the health of every woman and every nation. Every modest control have an enormous impact. Fortunately, most CVD in women is preventable. They gave us guidelines in the 4 steps. If we see from step 1, from the prematurity and age at the menarche up to the premature ovarian failure and the early menopause, we can see list of lot of diseases which can contribute in the productive years of the woman. So they should be screened. If there are sex-specific risk factors present in step 2, so access for the traditional CVD risk factors early and more frequently should be done. And success for to prevent and treat the intermediate phenotype should be performed, and in stage 3. So, should initiate the lifestyle modifications according to the AHA lifestyle sample 7. So, lifestyle modification should be started at the step 3. In step 4, estimate risk and treat the accordingly with the consideration of sex-specific risk factors. Assess 10 years risk, ASVD risk, and the lifetime risk, and treat patient accordingly in stage 4. So, coming to the screening and diagnosis, biomarkers, we know that high sensitivity cardiac troponin and natriuretic peptides usually provide valuable information about the myocardial damage and heart function and aid in identifying the cardiac injury and heart dysfunction in women, especially in microvascular dysfunction. But they usually assist in diagnosis and with risk stratification for the severity of disease as well. The recent advances in diagnosis and risk stratification, new serum markers of CVD such as C-reactive protein and lipoprotein A help in integration, and CRP shows promise of early detection but have uncertain clinical values since they may not help re-stratify women or intermediate risk. Advanced imaging technique, imaging tests such as coronary artery calcium scoring and carotid intimal medial thickness, too may fail to recognize women at long-term increased risks, and how to apply these tests clinically is uncertain up till now. Echography, yes, it can help in our routine practice. Cardiac magnet resonance MRI offers superior visualization of the cardiovascular anatomy and function. So CMR in future will be the test of choice in a woman with. So if we are talking about the age 45 or older, yes, breast arterial calcification seen on the routine mammography has been associated with the risk of death and cardiovascular outcome in the aging woman in 70% cases. The potential impact of extending CVD risk screening through the mammography is huge and will be huge in future as well. Coming to the more advanced technology, that is the AI and these digital tools, they will help us in future. If we are talking about the young age, then congenital heart diseases and family history of the cardiovascular diseases, we can assess with these digital tools, and with the help of these AI, artificial intelligence, ECG, hypertrophic cardiomyopathy can be assessed in young women. Prolonged QT interval also can be assessed with the help of this technology. And in cases of congenital heart disease, phonography, sounds assessment will be performed in future. Coming to the period when woman is in productive years, then one can screen the risk factors like hypertension.
Excuse me, Khalda, the time is up. 1 more minute, please,
Okay.
extra.
थोड़ा तो मुझे कोऑर्डिनेटर होने का एडवांटेज होना चाहिए.
नहीं तो फिर वो ये हो जाएगा ना, क्योंकि मैंने
I was
शाम
not
9:30 स्टेज से उतर जाना है. Discrimination is not permitted.
Okay.
चलो जल्दी करो, hurry up.
Okay. So, talking about the menopause, so menopause is a critical time when the woman should be looked after, as most of the time in perimenopause, she suffers from these symptoms. The early natural menopause, prior to 45 years of age, and surgical removal of the ovaries can also increase a woman's risk for the cardiovascular disease. So, take menopause to the heart. We all know that at the age of menopause, there are certain changes like decline in estrogen level, increased body fat around the organs, increased cholesterol level, and stiffening and weakening of the blood vessels. Usually leads to the cardiovascular diseases in women. So, and a woman can suffer from the metabolic syndrome, and highlighting 3 or more features of the metabolic syndrome. So, menopause doesn't cause the disease unless it is not looked after by the lifestyle modification by the woman. Regarding the estradiol, Dr. Taira Sadiq has spoken a lot about it. So the trial result of will bring back the confidence in estradiol therapy, which was found safe for the recently menopausal healthy women from a research focused on the lipid or fatty deposits that had accumulated on the wall of neck arteries during the early menopause. This therapy reduced the progression of fatty deposits by more than half of that seen in the placebo group. So, might be this drug will be again in the market, and latest advances in the medical care again allowed the if we are talking about the pregnancy, to women to conceive and carry pregnancy up to the term. So prevention began before the pregnancy with the preconception screening, and then we schedule her screening and a prevention plan. So what is the need? Need for the tailored approaches for the prevention, tailoring prevention approaches for the gender-specific risk factors, symptoms, for assessment of the CVD risk and prevention in the various life stages of the woman, especially personalized intervention needed in the lifestyle modification, pharmacological therapies, and close monitoring of the cardiovascular health factor, and by educating women about their unique and cardiovascular risk to educate their health. So, in conclusion, do we need a different approach to assess the cardiovascular risk in women? Yes. CVD risk stratification was traditionally similar to that in the men, leading to under-detection of the disease in women. Recently, accumulating evidence on sex and gender-based difference in CVD development and outcomes have led to women-specific guidelines, which have raised awareness of female-specific risk factors. The 80% of the CVD in women is preventable through the lifestyle modification and risk factor management in developed countries. So there will be need for more effective approaches to screening for the risk factor, and phenotypes in the women is ever urgent. Thank you so much.
Thank you so much, finally. Now, I had promised to get off stage at 9:30. Still, there are 2 more minutes. Just a quick comment. You have heard all the talks, and the moral of the story is that women are at a very high risk of developing not only heart, but cardiovascular problems. And in case of breast cancer, 1 out of 9 women will die of this breast cancer. Whereas for cardiovascular, 1 out of 3 will die of that. And then, Khalda mentioned, I always measure this intima to media ratio while scanning carotid artery. And lately, epicardial fat tissue, that is another indicator because that shares microcirculation with heart. And these ladies are obese. Dr. Shahbaz was talking about heart failure with preserved ejection fraction. Mostly the women are obese, they have hypertension, repeated pregnancy, and all that predisposes them to develop this high. Last word mentioned also about breast cancer. There is a correlation. Whenever I go to the breast cancer prevention function, they have a pink ribbon. And I always tell them that in future, 1 limb of this pink is going to be replaced by red. Because women who have breast cancer, it is noticed that they have higher incidence of ischemic heart disease. May that be the effect of chemotherapy, radiation therapy, or people are now thinking that there may be a common gene which affects both. And similarly, women who have ischemic heart at a younger age, they do develop breast cancer at a later stage. Promise, 9:30, I'm leaving the stage now, chairperson.
Thank you very much. I think I was supposed to be on the stage, but because this screen is not working, I'm audible to all. Screen is not working, that's why I'm sitting here, and I'm taking opportunity of this, because this was an excellent session, and Professor Khalda is doing this for many years. That's why she has a name, and everybody knows him, not in Pakistan, but every corner of the world. But being a student, what I learned from my medical school and from my early residency, that how to present in a medical conference and how to chair a session. The first thing I learned there, that be humble when you are sitting on the stage, because that's a basic, that's why we teach our junior colleagues. Today what I have seen, because every chairperson has same rights when he is sitting on the stage. So probably these things which Professor Nusrat Ara said to speakers, I think they can be said, these things, but in some different and good manner, because we are representing Pakistan and we are representing the whole of the world. Probably that's, I think, this is my opinion, that the way we have conducted session today, that can be conducted in better way, with better words, because Professor Khalda Sumro is coordinator of this GoRed. Then what the juniors will take lesson from our interaction, what we are interacting with the, in the first speaker was from outside, she was, I don't know from which country, but we can interact with them a polite way, and that's how we are being taught, and that's why how we should be an example for our juniors. Thank you very much.
Excuse me.
No, that's madam, that's my, I haven't put any question, that's my impression. And
So
if
madam,
you
isko
disagree, you have right, madam.
We got the
very polite.
message. I
Jokingly, I
think
told them,
there is
yeah.
one comment I want to make. Javed, thank you very much. We got the message. No doubt, it was a very well presented session, and we learned a lot of new things about the disease, cardiovascular disease in women especially. But I have two comments to make. Coming back to the post-menopausal hormone replacement therapy, what we see and what we read and what we gain is that it should be started within 10 years of menopause. Because after 10 years, they say there is no much difference, number one. Number two, there has been a long debate about lipoprotein small a, and still there has been no effective treatment for that. But one thing which is very promising, again, this post-menopausal hormone replacement therapy, this has shown a very positive effect in decreasing lipoprotein A. So at the same time, I am not commenting, I'm not saying that males should also start taking it, but for females in post-menopausal, this is one very additional help from hormone replacement therapy.
Can I say
Actually,
something
when we-
on this?
When we talk.
I'm a very old one, so 30, 40 years back, this came into the discussion that hormone replacement therapy helps in prevention of the cardiovascular diseases. Later on, with the many studies, it was thought that though there was an improvement in the ischemic heart disease, but there was more thrombogenicity, because the estrogens are thrombogenic. So overall mortality or morbidity remained the same, because ischemic heart disease could be prevented, but the thrombogenicity was increased. Can somebody elaborate this?
You may be right, but these what you are talking about the studies they are past about decade or back.
Of my age.
Yes, but now what the studies are showing is, this is what I told you, that hormone replacement therapy has become a standard for treating post-menopausal women, especially when they get symptoms as well. And even those autonomic symptoms like sweating has been related to increase in cardiovascular mortality, like hot flushes and sweating. But especially what they talk about is about sweating. So nowadays, if they combine the progestin with the estrogen as well, and that is quite safe. So these are the latest studies. Thank you.
Thank you, sir. Since I hail from the little town of Sakhar, so I have seen that a lot of problems are there in diagnosing, especially females suffering from ischemic heart disease. So diagnostic challenge is one which has been talked, and Professor Khalda has been there at Sakhar 2 weeks before. She is doing very nice things. And one important thing that we are working there on peripartum cardiomyopathy. Along with the gynecologist, we have some few studies, and I have found in those that there is large number of heart failure, especially in females who are pregnant and delivering. So that should be also seen in the context that why that is arise. Probably we are not up to the mark in controlling that. Thank you.
One last question, please, and then I'm going to declare the session closed. Kaun? Ji, Dr. Nazir, I'm sorry. Yeah, you wanted to ask me.
Thank you very much indeed. I wish to thank the organizers for inviting us for this wonderful conference. My suggestion will be to have few talks so that we can have enough time for question and answers. Number 3 is that if we stay relevant, I'm talking about GoRed for men, for women, and D stand or stood for don't stop talking. I think don't stop talking, but be relevant. This is a rather new field, and we are all learning. And this is a learning experience, and therefore we don't expect guidelines to be there in a hurry. All of us have experiences, and we can share that. And I think, generally speaking, I agree that the speakers, although should be told beforehand, but they should be allowed a bit of a freedom also. But more time should be for questions and answers, and that's all I have to say. Thank you very much indeed.
Thank you. Thank you.
May I ask a question?
No, I think we have ended the session. If you
Okay,
want quickly, jab tak hum uth rahe hain, pursa kar.
Okay, I just wanted to add a comment around regarding the microvascular disease. Nina and Nanant and Dima excellently presented the microvascular disease. The actual numbers are much more as compared to international data in our population, and I think that in our population, a large number of women are going undetected. And the good thing is that presently in Pakistan, we are diagnosing this issue with the availability of MFR in our settings. However, the downside is that sometimes the microvascular disease is with or without epicardial disease. So that's the real issue, and sometimes patient gets the intervention that further worsens the outcome. Thank you.